Alright everyone, let's talk about plantar fasciitis as a clinical case that can come in your exam. So we have done Morton neuroma before, or metatarsalgia, which is quite similar. So you will find the mind map is quite similar because they both follow the same approach, relatively the same management as well. So what can be the scenario for plantar fasciitis? How a real patient can come to you with plantar fasciitis? That will be someone who is coming with heel pain in the heel bone or pain in the foot. Okay, and when you talk to the patient, you will find out that he has a risk factor of standing for a long time, because it comes because of repetitive strain actually on that area, okay, or in the fascia already. So you will find that this is someone who is standing for a long time, maybe a hairdresser, maybe a shopkeeper, maybe someone who is selling something in a shop or so. So he will have that risk factor for you to address. When you examine, it will be typical examination finding of plantar fasciitis. You can watch a 1-minute YouTube video for the examination. It's quite simple. A normal patient will ask you, why do I feel that pain? So you need to answer that quite easily. And again, he may ask you, why do I feel that pain as well? Like, why me? Then you can give the risk factor. It's likely because of your job. Standing for a long time is a common risk factor for that. Treatment options, we'll know that in a minute. So as you know me, I will not give you the mind map straight away. I will teach you the right thing first. I will show you how is that taught in the NICE guidelines, so you can feel confident when you discuss the mind map. So let's see what is written first in NICE, CKS and NHS, so we know the right information here. So plantar fasciitis as a definition, and this is how you define it to the patient in a simple language, that is pain on the bottom of your foot around your heel and arc. How would you know it is plantar fasciitis? From the story wise, the patient will come with typical picture of plantar fasciitis. What is that typical picture? That will be pain in the foot, which gets worse when you start walking after relaxing or after being sitting for a long time. So the characteristic of the pain, that it starts when he starts walking after resting, and then it gets better by walking more, and then it comes again after resting. So that is the cycle of plantar fasciitis pain. So when you ask the patient about Socrates, what makes it worse? For example, doctor, sitting for a long time, it makes it worse. What makes it better? Actually, doctor, walking or doing some exercise makes it better. And of course, you can have some difficulty raising the toes because that will stretch the fascia. So that will be the classic picture of that patient again, and he will have some risk factors such as being overweight or doing a job with long standing included in that. So when you talk about management, after you give a definition of diagnosis, you will talk about management as a patient part and the doctor part, the same as we do in every mind map. We advise the patient about things he can do to ease his symptoms and things we can do as a doctor to help him as well. So the advice or the soft advice you can give the patient will include things like resting and raising the foot, using some ice massage, for example, doing that for 20 minutes every few hours. Of course, using comfy shoes and insoles can be quite helpful. He can do some self exercises as well, and he can use some over-the-counter painkillers to ease the pain. And if he's overweight, you can advise about losing weight because that is a risk factor. You can advise him as well not to walk or not to stand for long periods, which was our risk factor. Do not use high heels or walking barefoot as well. So as you can see, quite easy. You will find everything in the mind map in single piece in a minute here. So let's talk about the doctor part. The first thing in the doctor part, you can reassure that usually most people will make a complete recovery within a year. That is as it is mentioned in NICE CKS. Okay, and after we offer some help with self-physiotherapy, with trying over-the-counter medicines, you can signpost that we may need to refer you, or we may need to seek help from the physiotherapist or foot specialist who can help you as well to cope with that. Or if it does not get better by the coming few weeks, we may need to ask our colleagues, physiotherapist or foot specialist, to help with that. And how they can help: physiotherapist can help with some physiotherapy exercises, as well they can offer injection like a steroid injection, which can help the patient, but that's not a first line, that is maybe a second or third line. So you try what he can do to help, what you can do today to help as a doctor, and then you can say if things are not getting better, we may consider referring you to the foot specialist or the physiotherapist. They may recommend that and that and that, or they may recommend injection, which can give some relief as well. If things are failing and we are not able to control your symptoms, we may need to refer you to the bone specialist. That is usually the last resort, guys. The bone specialist can do what? Can offer more advanced options of treatment, for example like shock wave therapy, and you can talk about that in simple language. That is non-invasive treatment that involves passing shock waves through the affected area, and as well they may offer surgical division or surgical treatment for that if deemed necessary. That is usually a last resort if things are quite extreme. So now you have seen everything as it is written in the guidelines. Let's see the mind map examination. As I told you, 1 minute video on YouTube will be quite enough. It's a simple examination. You will find tenderness in the area of the heel, the area of the fascia, and as well you will have limited ankle dorsiflexion because that will stretch the fascia. There is a test called the windlass test which will be positive as well, and of course tightness of Achilles tendon and antalgic gait can be present here. So quite easy examination. 1 minute will be more than enough for that examination. Just watch any simple video for that. Let's do the mind map as a clear cut 12. I'll start by the presenting complaint. He's coming with foot pain. I will ask an open question. Can you tell me more about that? So the first step is usually exploring the presenting complaint, and after that you complete Socrates. And it's very important because Socrates will give you the right diagnosis. When you ask the patient, can you describe the pain to me? Where exactly is the pain? He will tell you in that area, in the plantar fascia area. And when you ask him what makes it better, then he can tell you walking can make it better. What makes it worse? Usually sitting or resting. And of course, that will be quite typical for that case. So that is our first step. Second step in presenting complaint, you ask about trigger. Was that triggered by anything at all? Why? Because trauma or injury may be one of your differentials. So trigger is always my healthy question in every single mind map. And then we complete our presenting complaint by asking about other, and usually other includes 3 angles or 3 others. The first one is other for the patient to help you. You ask an open question, Mr. Smith, with that foot pain, do you have any other symptoms at all? He may give you the symptom of not able to move his toes freely, or maybe some stiffness or so. The second other for you to ask the patient about other symptoms of the same system. So he's coming with foot symptoms, so you will ask about other symptoms in the foot, for example any swelling, any redness, any numbness in that area. The other is the other side. How about your other foot? Is it okay, or do you have any symptoms in the right foot as well? No, doctor. Yeah. So with that first step, you will always get the right diagnosis, clear cut. Second step, as we do every time, closed-ended questions for differentials or red flag. So what can be a differential? In that case, 3 things only you need to ask about them. Do not go more crazy than that. For example, infection or gout can be a differential, so you can ask about any spiking temperature, any redness or swelling in the joint area. That will be negative. Of course, you can ask about other joints, especially if it is a systemic problem, for example like rheumatoid arthritis or so and so. You can ask about any stiffness or any morning stiffness at all. Do you have any other pain in other joints as well? Of course, you can ask about any nerve damage. As you know, for motor neuroma we can have that, such as numbness or tingling. So as you can see, 3 simple questions will make the story quite clear. Do not go more crazy than that. Go to the third step, which is general well-being of the patient or relevant maftosa. Ask him past medical history. Have you been diagnosed with any medical problems at all? For example, diabetes or things that can increase the risk factor. For example, are you taking any medicines on a regular basis? Or ask about medicines that he tried. Have you tried anything to ease your symptoms? He may have tried paracetamol already. Family history of joint problems will be the risk factor or the relevant question. Do not ask maftosa as a routine maftosa. It should be relevant maftosa. Of course, social questions, you can ask about smoking or alcohol, but what will make a difference is activity, and is that stopping you from anything you do, for example, or do you do any kind of sport or activity? If he's a runner, for example, that may be a risk factor, repetitive movement. And then we end data gathering by psychosocial and ICE. Ask psychosocial how that has been affecting you. Has it been stopping you from doing anything you used to do? He had it for maybe 2, 3, 4 weeks. Maybe it's stopping him from running or from doing some activity. So ask psychosocial, and he may actually tell you, doctor, it's getting worse at work. I stand up for a long time. What do you do for a living? Doctor, I'm a shopkeeper, or doctor, I'm a hairdresser. That is very relevant information for you, because when you address that that in the management, you get the clear-cut 12. You end the data gathering by asking ICE, what do you think may be the cause of that? He may give you his idea. Ask him if he's concerned about anything. Is there anything in particular you are worried about? Ask about expectation. Were you hoping for anything specific I can offer you today? So listen to your patient here. Examination, easy peasy. You will examine the foot, of course. That's a 1 minute examination maximum. And as you have seen in the guidelines, it's quite clear examination. Yeah. So start your management. Keep at least 3 minutes for management if you are planning to pass PLAB 2 with 12 out of 12. So start your management, having listened to Mr. Smith, having examined you. It seems what you are experiencing is what we call plantar fasciitis. Have we heard about that term before? No, doctor. Then explain it in a simple language. That's a painful condition of the foot caused by repetitive strain to the band that connects your heel bone to your toes. That is the band which you call plantar fascia. Am I making sense? Yes, doctor. He may ask you why. Then you can tell him. If he's overweight, for example, you can ask him, or you can tell him that being overweight, the risk factor, standing for a long time, would have caused you that risk as well. So start your management. To help you with that, Mr. Smith, there are a couple of things you can do and a couple of things we can help you with as well. Things you can do, bring from the nice guidelines. What was the soft advice? Advice again, Mr. Smith, having some rest and raising your foot would usually help. Trying some ice massage can help as well. You can do that 20 minutes at a time every few hours. Wear comfy shoes and soft insoles would help as well, and would strongly suggest if you avoid any prolonged standing or waking barefoot. For example, if he's working, as I told you, maybe a shopkeeper or hairdresser, maybe taking some rest in between your work hours. Yeah. Things we can offer you would advise you that you can use some over-the-counter painkillers such as ibuprofen or paracetamol. They tend to help. We'll give you some exercises that you can do at home that would usually stretchen and strengthen the fascia. So you can give him a leaflet about self-exercise. And if you're not getting better by that, we may need to refer you to our colleagues, physiotherapist or foot specialist, the podiatrist, who can help you with targeted exercises or so. Mr. Smith, if things are not getting better over the coming 2-3 months, for example, and you're not getting better with what we try, there is an option that we may need to consider later, which is referring you to the bone specialist, and they have more advanced options of treatment, such as sometimes injection inside the foot, sometimes shockwave therapy, and you can explain that as we have seen, and sometimes even surgery, but that's usually a last resort. Let's have a follow-up. Mr. Smith, you can offer a follow-up maybe in 1 or 2-3 months, guys. Usually these musculoskeletal problems do take time, so maybe offer 4 or 6 weeks follow-up will be quite sensitive to that case. Apart from that, as you can see, it is 12 out of 12 case for my team Alpha. Before I finish, as you know, we have a package of all cases in a similar mind map, every single case that you can imagine in a similar mind map and with the guidelines explained as well. If you'd like to join, you can contact me on that number, and with the mind maps you have access to everything else like SIMMAN, examination, management mechanics with me, which is management, practice every week with me to master the style. My team, get 12 out of 12. I wish for you the best. Thank you.